Dr. Noreen Womack. Dr. Womack graduated from medical school from the University of Texas Medical Center, completed her pediatric residency at Duke University Medical Center. She served as the early childhood champion for the Idaho chapter of the American Academy of Pediatrics. And I can tell you that she is really a children's champion, and we're really happy to have her here. And her special interest is in adverse childhood experiences, resiliency, and early literacy. And she serves as a guardian ad litem for the Fourth Judicial District and volunteers in adult hospice care. She's co-founder of the Idaho Children Are Primary, a bipartisan organization that highlights children's issues in the Idaho legislature. So we're just really happy to have you here, Dr. Womack, and really looking forward to having you talk. So go ahead, take it away.
Thanks, Bill. Okay, bear with me. I'm going to try to share my screen. Can y'all see my screen yet?
Not yet.
Nope.
This has never done this before. Cam, I might need you
Yeah,
to
that's no problem.
pull my slides up for me. And unfortunately, I won't be able to drive them, but
Yeah, just let me know next slide.
okay. Okay. Thanks, Cam. So I have been asked to talk about early brain and child development this morning. So let's get right to it. Next, please. So I do have one question, Cam. Can people see my pointer at all? Probably not, right?
Probably no.
Okay, that's
But
okay.
I can try to point for you.
Okay. All right.
Okay.
So sorry about that. So I have no financial disclosures, but I did want to say that we are in our second year of a grant through the CDC and the AUCD, which is the Association for University Centers for Disabilities. And I am with Melissa Christ, who is the director of Idaho STARS and also the Idaho Act Early Ambassador to the CDC, as well as Janice Fletcher, who is Professor Emeritus at the University of Idaho and expert in all things data and analytics. And the green states are the states that have been awarded this grant. And the main purpose of the grant is actually much in keeping with today's topic. It is all around promotion of developmental monitoring and screening through a resilience lens. Next, please. So here are my objectives today. I only have three main objectives. So we're going to talk about early brain development. We're going to talk about adverse childhood experiences. We're going to talk about mitigation of those experiences. And at the end, I'm going to have homework for you that I put in red. It's going to seem like my other objective is to overwhelm you guys with a lot of busy slides and a lot of information, but I am assured that you will get a copy of my slides as well as the recording. So, and then I'll have my email at the end if you have any questions. Next slide, please. So here's our first critical concept. Childhood is for learning. And this should seem, like a very logical statement, but really that's exactly what childhood is for. Those of you who have been at my presentations before know that the human baby brain is the least developed brain of the entire animal kingdom. And that is because we build our brains from scratch. So if you take, for instance, a baby shark, they don't have any childhood. They're completely independent from their mother and father. As soon as they're hatched, they can survive. They can find food. They have everything they need in their brains to survive. Let's take an example of a baby crow. So certain species of crows actually are dependent on their parents for upwards of 2 years. And the reason why is because those baby crows are also developing their little baby brains. And so they need their mother and father to protect them and to feed them while that's happening. And that's why they end up happening to be one of the most intelligent species of birds. And it turns out through animal studies that the longer your childhood is, then the more intelligent you are as a species. And human beings have the longest childhood of all animal species. Legally and arbitrarily, that's up to 18 years of age. But we now know that actually it's about 23 years before the brain completely matures. And it's even later for males. So sorry, guys. So next slide, please. So this is a statement from the AAP, or American Academy of Pediatrics, and that is the first 1,000 days of life offer a critical window for social and emotional attachment with rapid brain development that does not occur at any other time. Next. So this is a statement from the National Institutes of Mental Health. The brain grows rapidly during the period before birth and then slows considerably during the preschool years. So the reason why I have a picture of my son on fetal ultrasound is to remind you that that first 1,000 days does include prenatal growth as well, prenatal brain growth, so before birth. And then half of the postnatal growth of brain volume actually occurs in that very first year of life. And so by the time you are a kindergartner, your brain weighs already 90% of what it's going to weigh ultimately. Next slide, please. This is a microscopic view of baby brains. So on the left is a newborn brain, and you can see there are a few neurons or nerve cells. And then at 6 months, that same microscopic view, you're seeing not just more neurons, but the more connections between them. And then by 2 years of age, really have multiple connections and multiple neurons. So if you are creating 700 new connections per second, that translates into billions of cells and connections by the end of this period. Next, please. So this head circumference graph should look familiar to the parents in the room because in your well checks in the first couple of years of life, we measure head circumference. And the reason why we do that is because if the brain doesn't grow, the head doesn't grow. So before that slide showed a microscopic view of what's happening, and this is the macroscopic view of what's happening. And if you look at the left of the graph, how exponential that line goes up, that's just telling you all of those brain cells that are being formed, expanding the head circumference in a pretty dramatic way. Next, please. So there are a few things that the human brain needs in early childhood. Some of those things are free play, learning how actions affect your immediate physical environment. Next slide. But the most important thing that an early human brain needs is that social and emotional attachment. You cannot have brain development during this period without it. And in especially the first years of life, that looks like serve and return interaction. It looks like this picture. So one way to think about serve and return interaction is to think about tennis. So in tennis, one player serves a ball and then the other player returns it. And that's exactly what's happening here. A baby reaches out to an adult either by vocalization or movement or facial expression. And then the adult does that same thing back to the baby. That's really all it is. But it happens over and over again, day in, day out. And that's what creates that those emotional bonds. And it's important to note that serve and return interaction cannot happen through a screen. So I hate to break it to the grandparents that, Skype with the grandbabies every weekend. There absolutely is value in that, but babies can't really count on that for that attachment piece. And there's been multiple studies showing that. So under about 30 months of age, you really need all of this to happen in person. It cannot happen virtually. The other fun thing that they did as a study was they hooked up EEG or electroencephalogram electrodes to the heads of babies and adults while they were participating in serve and return interaction. And the places in the brain that lit up are the ones that are associated with joy. Next slide, please. So why is whole milk recommended from age 12 to 24 months? The answer to that is a lot of people just say brain development, but it actually is myelination, or the process of myelination. Circled in red, I'm showing the myelin sheath, which is in blue. This is a picture of a single nerve cell. You can see the body of the nerve cell, and then the axon is that long part that connects to other nerve cells. What happens when a baby is born is that they don't have any of that blue stuff, that myelin sheath. All of that myelin sheath gets put down or developed after birth. And that myelin sheath, that blue stuff, is actually made up of a fatty substance. And there is so much myelination happening in the first couple of years of life that you actually need extra fat in whole milk versus skim milk to make sure that you have enough lipid and fat to lay all that myelin sheath down. Next slide, please. So myelination happens in a very systematic fashion. It happens in a cephalocaudal fashion, and it also happens in a proximal distal fashion. So let's take cephalocaudal first. So cephalic just means head in Latin. Caudal means tail. And so myelination progresses from the head, and then it goes down the body all the way down. As an example, let's take gross motor development of a child. So a newborn can't hold their head up at all, right? So when you're holding a newborn, you have to use one of your hands to cradle the head. Then at about 2 to 3 months of age, that myelination process goes from the head to about the cervical or neck area. And so that way, a 2 to 3 month old has better head control, and you don't have to cradle their head as much as a newborn. Fast forward a couple more months, that same myelination process has now gone down to the upper thoracic area, including the arms. And so if you put a 4 to 5 month old baby prone or on its tummy, what it can do is, because it's got the myelination in its arms, it can kind of push up, right? And then it gets a little unstable. And so, boop, they roll over. A couple months later, that myelination process goes to about the thoracolumbar area. And so you've got better truncal tone, you've got better core. And so if you sit a 6 to 7 month old down in sitting position, they won't immediately flop over because now they've got that truncal tone. And then finally, the myelination process goes all the way down to the lower extremities. And then you have the 12 to 15 month old that can walk. Next slide, please. So speech development occurs similarly, and the myelination happens in a proximal distal fashion. So proximal just means closer to the center of the body, and distal is away from the center of the body. So let's again take a newborn, think about what they can do. They can coo and they can vocalize, but they can't make consonant sounds. They just go like that. And then when that myelination process starts going distally, then they can start making consonant sounds. So all of y'all are muted. So I want all of you guys to make the sound g, g. When you make the sound g, think about what part of the mouth you're using. You're using the base of your tongue and the back of your throat to make the g sound, because then as a newborn matures and gets the nose nerves get myelinated, you can create that g consonant sound. Then as you get a little bit older, you can say duh. So everybody make the sound duh, duh. Think about where that is on your tongue. So as you make the sound duh, what you're doing is you're using the tip of your tongue and you're putting it to the roof of your mouth. Again, because that myelination process has now gone distally enough that you have now control of the distal part of your tongue. If you make the sound ma, ma, now we're talking distally all the way to the edge of the lips. And so your lip muscles are now getting involved. So now you can make the m sound. And there are many, many moms that are upset because usually a baby will say dada first before they can easily say mama. And it turns out it's just because of myelination. It's not because they love daddy more than they love mommy necessarily. It's just a little bit easier to say because of this myelination process. Now the S sound is actually a fairly complex sound to make. And if there are any speech therapists in the audience, they already know this, but the reason why lisping or not being able to say the S sound is such a common speech delay is because that is one of the more complex sounds to make. It's the last sound that can be made at the end of the process of myelination. So, you know, a lot of toddlers lisp, and sometimes it does persist even beyond the toddler years. A little fun fact, I lisped when I was younger and I had to do speech therapy, and I hated it because it meant that I had to skip art. But anyway, it's very common. Next slide, please. Language works a little bit differently. I want all of you guys to try to find your age down on that x-axis down there, and then know where your language score is, which basically means your ability to learn language and pick up a new language. It's pretty high before the age of 7, and then obviously it drops precipitously. And before you get too depressed, my age isn't even on this chart anymore. But what Dr. Kuehl did is some amazing studies that show that really, again, that first year of life, from birth to about 18 months of age, that is when you are the best at picking up any different language, including a second language. And that ability actually starts dropping at about after the age of 7. So that's why I like to make sure that families know that they can encourage their children to learn if they have a native language other than English, you know, encouraging them to learn that language when they're young, because that is the window of opportunity to learn that second language. Next slide, please. So this is how we categorize development. So there's movement or physical development, which is gross motor, which are the large muscles of the body, and fine motor, which is all the hand muscles. Cognitive, language, and social emotional. And then milestones are the benchmarks for development in these separate domains. So for instance, walking is a milestone in the gross motor category. Next slide, please. And I don't know how many of you guys saw this, but just this week, like a couple of days ago, the CDC and AAP just published their new developmental milestones. And this is the first time in recent memory that these milestones have been updated. I want to say it's been a couple of decades since milestones have been updated. So, you know, this was a very well-timed conference because we can talk about these new milestones. This does not mean that the older milestones that we're currently using are wrong. You can actually continue to use them. We have materials with the old milestones that we will probably continue to use until we get these new ones published. But they're just a little bit different. And so here are some of the differences outlined in this slide. First of all, they're more evidence informed. Some milestones were just kind of made up and there's not a lot of research around them, and they tried to not use those as much. What I think is the most important part of these new milestones is that they're only using milestones at the ages where 75% of children would be expected to achieve that milestone. Before, the milestones were 50%. So for instance, walking is a very common 12-month or 1-year-old milestone. But actually only half of children are walking by the age of a year. So now that particular milestone has been moved to 15 months. And so the reason they did that is to discourage that wait and see approach, because if a child wasn't walking by a year, it almost gave us permission to say, well, half of them just aren't anyway, so let's just wait and do their development, you know, when they're 15 months. So you're kicking the can down the road. So hopefully there will be less of that with these new milestones. They also took out any milestones that couldn't be easily observed in natural settings, and they added some milestones at certain ages. And so at the end of this, what they saw was a 26% reduction in milestones and then 40% replacement of previous milestones. A third of the retained milestones, like walking, were transferred to different ages, and 67% of those were transferred to older ages. They are going to include in the chat a link so that you can take a look at these new milestones on the CDC website. Next slide. So how do we track development? There's two main ways. There's developmental monitoring, also called surveillance, and developmental screening. So one is a more informal process and one's more formal. So the informal process, which is developmental monitoring or surveillance, can be done by anyone. In fact, it's best done by who knows the child best. So that's the family. We have milestones from birth to 5 years, and you can really do it at any age, but we have certain ages that we have them available. And it helps a family celebrate their child's development. It helps communicate with child care providers and healthcare providers, and it can help identify concerns early. Developmental screening is a more formal process. It uses a validated tool and typically needs some sort of instruction or training to be able to do the developmental screening. As pediatricians, we do screenings at 9, 18, and 30 months. And there are multiple different screening tools. One of the more popular ones is the Ages and Stages questionnaire. And one important point I want to make is that routinely talking about developmental monitoring and development in general makes milestones something that the family believes is important, because it is. So the more we talk about it, the better. I don't want you to ever think, oh, they're going to get this done, at their next doctor appointment. They can wait till then. No, the more you talk about it, the more we monitor and encourage the families to monitor, the better. Next slide, please. So that was a little primer on early brain and child development. And now we're going to turn to childhood trauma, which is a major disruptor of child development. It also is a cause of half of the top 10 causes of death in the United States. Next slide, please. So most of us at this point are familiar with adverse childhood experiences. The original ACEs from the study with Dr. Flitti and the CDC are listed above. And then there are also the adverse community environments listed below that have been added as significant factors contributing to ACEs. And I stuck COVID-19 down there in the roots because I think we all agree that that is certainly contributing. And this is probably an underrepresentation, but the last number I saw last fall is that 500 plus children in Idaho have lost either a primary or a secondary caregiver to COVID-19 since the beginning of the pandemic. Next slide, please. So a word about stress versus toxic stress, because I actually have heard people use this incorrectly. So normal stress is a good thing. Everyday pressure that pushes us to perform, takes us out of our comfort zone, usually temporary and has an activating effect. So that is, taking up a new sport or knitting or learning how to do yoga or taking a vacation in a place that makes you a little uncomfortable, things like that. Those are actually stressors, but overall a positive experience. And actually humans need that. Tolerable stress are negative events, but they're buffered or can be buffered. I like to use the example of a child who breaks their arm. If you break your arm, of course, that's negative. It's painful, but if a child breaks their arm, typically there are people around them that will help them with that. And that child can either practice their existing coping strategies or learn new coping strategies. So by the time they get through that, they could look back at it as a growing experience. Toxic stress is never positive. It is chronic repeated stresses, often committed by those who were supposed to be the ones supporting you. And they are overwhelming in terms of children's capacity to cope. Next slide, please. So on this slide are all of the effects all the effects of toxic stress on a growing and developing human being or a child. They are devastating and sometimes last somebody's entire life, and are the reasons why adverse childhood experiences can be connected to half of the top 10 leading causes of death. So this one slide is an hour lecture unto itself, but just really quickly: alterations in brain architecture, changes in genetic expression, immune suppression leading to increased infections, endocrine imbalance, so that is the chronic activation of the hypothalamic pituitary axis, which leads to consistent or continuous flushing in our system of norepinephrine, epinephrine, which ends up damaging end organs. You have decreased affect regulation, so decreased emotional regulation, interference with relational health, so that's like emotional attachment disorder, behavioral allostasis, which is one of my favorite things to talk about but can't touch on at all today, and then all of that eventually leading to the chronic illness and health disparities, and upwards of 20 years decreased life expectancy. Next slide. So if you could just click through, because it's going to populate the rest of the slide. Yeah, I'll tell you when to stop. Keep going. So pay attention to the colored, that's it, thank you. Oh, thanks. So pay attention to the colored labels, because these are the ones we're going to talk about in terms of changes in brain structure with toxic stress. So the amygdala is in charge of reactivity, impulsivity, and emotional regulation. And the prefrontal cortex is in charge of executive functioning, thinking before you act, things like that. What happens with toxic stress is that you have increased neuronal connections in the amygdala and in other areas like the nucleus accumbens, and you have decrease or pruning of nerve connections in the prefrontal cortex. Next slide. And then click through, please. And stop. Thank you. So it should come as no surprise that the more adverse childhood experiences you have, which are on the x-axis, then the higher your chance of having developmental delays. But I want you guys to pay attention to the shape of this bar graph, how there's that one-to-one correlation almost between developmental delays and ACEs. Next slide. Because you're going to see that same shape of bar graph when you have ACEs on the x-axis with smoking. Next slide. With attempted suicide. Next slide. IV drug use. Next slide. And finally, adult heart disease, which is the #1 killer in the United States and happens to also be the most expensive medical condition to treat. Next slide. And unfortunately, adverse childhood experiences in our state are very common, much more than other states. And there are 65% of Idaho adults that have reported at least a score of 1. And the really chilling statistic is that there are nearly 1 in 4 adults in Idaho that have reported an A score of 4 or more. And if you have an A score of 4 or more, we know that your risk for suicidality, so that's suicide or suicidal ideation, is 12 times that of someone who has an A score of 0. So just having an A score of 4 increases your risk for suicidality 12 times. Next paragraph, or sorry, thanks. So there has been declared a national mental health crisis in children by the AAP, by the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association. This is from last October. And I'm going to give you guys one guess as to which state has the worst mental health disparity. What that means is children requiring mental health services versus the number of mental health care providers available to give those services to those children. So which state, one guess, has the worst disparity? And you've guessed it, you're living in it. Next slide. Here's a little good news. So just 2 days ago, I was looking through my my inbox, and this came out in it's an AAP daily briefing. It's just an email of news, and this article says that the U.S. Surgeon General states that the pandemic has had a devastating impact on mental health of young people. Well, that's not news, of course, but if you look at where the green arrow is, his main recommendation was to ensure access to high quality, culturally competent care, focusing on prevention with school and community-based programs, which I'm like, oh, that's you guys. Next paragraph.
Noreen, I have a question here related to that.
Okay.
The question is, I wonder why children experience more ACEs in Idaho. I wonder if it has to do with the lack of providers.
We don't know. That's a good question. I don't know if there has been that study has been done, but you're correct. I'm not sure what they meant by providers, whether that's mental health providers or healthcare providers. But yes, Idaho does have less of both of those versus other states. So I wonder too, there's a lot of factors. You know, we're a rural state. So yeah, I wonder as well. So I'm sorry I didn't answer that question, but it's a good one. So I just, in the past, when I've given talks about ACEs, this is kind of where I would stop the talk because, 10, 15 years ago, we didn't have much more information. And I remember once someone coming up to me and saying, all you did is just hand us a crap sandwich. I'll never forget that because it was pretty funny and in a dark way. But at least now we know more about how to mitigate those ACEs, and that's what we're going to turn our attention to next. But it sometimes is kind of hard to not despair. I don't know about you in your daily work, but my daily work has been much more difficult. I have seen a lot of hurting families. I met a human trafficker who looked me in the eye and said, I'm just trying to help these families while she was trying to recruit a patient of mine who was a 12-year-old Honduran who was undocumented, a little girl. I've had a kindergartner sitting across from me who I was seeing because he stabbed another kindergartner with a pencil. And come to find out, his dad is a white supremacist, and his mom is a victim of domestic violence. Just last month, I saw an 18-year-old who left her mom's house because her mom didn't care that her boyfriends were trying to sexually assault her. And so she's now living on her own, working a job, and trying to graduate from high school. And she doesn't have a car, she only has a bike. And she told me that when she bikes to school every morning, she thinks about what would happen if I just rode my bike in front of a car. So I don't know what your experiences are, but that is just a little bit of what I have been experiencing in my work. And so it's hard. And I found this definition from the Merriam-Webster Dictionary of a dumpster fire, which is an utterly calamitous or mismanaged situation or occurrence, which seemed a little appropriate. So next slide, please. So yes, we are going to turn our attention from ACEs and toxic stress because I think we're all turning more from a deficit-based to a strength-based approach, and that our research is now focused on prevention and mitigation of ACEs and toxic stress. Next slide. So this is from Dr. Tom Patterson. Your ACE score should not be your destiny. I shouldn't be able to say, hey, your ACE score is 4, so you're going to be at 12 times risk for suicidality than someone who doesn't have an ACE score of 4. That, we should not be able to predict your lifelong health from your ACE score. If we worked on mitigating toxic stress, we could have 30,000 fewer people experiencing depression, and this is Idaho. 60,000 people not smoking, preventing 30,000 cases of asthma, and even reducing unemployment by 15%. Next slide, please. So I think most of you are familiar with the 5 protective factors from the Strengthening Families framework, but this is evidence-informed factors that promote resilience. So they include parental resilience, social connections, so positive relationships. And then I've highlighted knowledge of parenting and child development because that's what we're talking about today. Understanding child development and parenting strategies that support physical, cognitive, language, social, and emotional development. Concrete support in times of need. And we're going to talk a little bit about Maslow's hierarchy in a little bit. And then finally, social and emotional competence of children. Next slide. So never mind. let's go to this. So no, go ahead. Yeah, thank you. So take your own pulse first. What I mean by this is, so when I was in training a long time ago, when they were teaching us how to run codes, they always would say, what do you do first? And the answer was, take your own pulse. And I think what they meant by that is, before you can run a code, before you can help a patient, you have to understand where you are first. And I would give that same advice to all of you. You are in the business of helping people. You're in the business of helping families and the people at work. But you can't do that unless you take your own pulse first. So you have to, if you are a victim of abuse, if you have had adverse childhood experiences in your life, if you've experienced toxic stress or PTSD, you have to acknowledge that, and you have to understand what that means for how you interact with other people and how it affects your behaviors and your own actions. Next slide. Once you have done that, once you've taken your own pulse, then you can help other caregivers acknowledge their own stress and their own childhood trauma if it exists. Because it's hard to raise kids, right? They have colic, you have to teach them how to use the potty, they have temper tantrums, and imagine how difficult this would be for a parent who is already at risk, who has had their own trauma to deal with. And that picture on the left is actually me. And my son, when he was 3 years old, I have to this day no idea why he completely lost it during his 3rd birthday, but he did. But think about how traumatic those events are. And if you're already dealing with your own trauma, what is that going to mean in terms of your reaction to your child? How are you going to react to their behavior? Next slide, please. So that is where you come in to help families. You are the experts at identifying the parents who are at greatest risk. You, with your relationship with them, can bring their trauma histories out of the closet. And it's not that you're being prying, it's that you're trying to help them. And the first step to doing that is identifying that history. And always, trying to support them in a non-judgmental way. We always feel like we're being judged. Even when I go to the doctor for my annual, I feel like they're going to judge me because of my weight or my blood pressure. I mean, it's just a natural human reaction to feel like people are judging us. And so many families and parents feel that already. And so trying to convey that, no, that's not why we're here. We're not here to judge you. We're just here to help you be a better parent. Next slide. So most of you are familiar with Maslow's hierarchy of needs, but I like to put it here to point out that a lot of people right now are living in the bottom of the pyramid. So physiological needs on the bottom, that's, food and shelter. And you have to have that before you can be a good employee, and take care of your health. And you need that before you can form healthy relationships with friends or with boyfriend, girlfriends, or spouses, other family members, which then can lead to self-esteem and then eventually, being the best person that you can possibly be. And this is not something that happens in a stepwise fashion. We can go from one to another. We can be bopped from love and belonging all the way back down to physiological needs. But just know that the people that we work with are, a lot of them are working on the bottom here with just the basics. So try not to judge if somebody's kind of snappish at you, right? Or if somebody seems to be having a bad day or yells at you, try not to take it personally, because a lot of people are living on the bottom there. Next slide. So parent trauma and why it matters, and why we as people who serve families need to think about it. Click again. So correlations exist between parent ACE scores and child ACE scores. I don't think that anybody who works with children and families would dispute that. The more ACEs a parent experiences, the more ACEs a child is likely to experience. Click again. So there was a pediatrician who said that unless you try deliberately every day not to, you will parent the way you were parented. So unless you deliberately make efforts to not do so almost on a daily basis, you will become your parent. And that turns out to be a bit true. Parenting styles are at least in part inherited. Excuse me, if a parent experienced harsh parenting, they are more likely to engage in that same style. Next paragraph, or sorry, next slide, or click, thanks. Parents have new brain growth in the first 6 months of life, first 6 months after their child's birth, in both the amygdala that we talked about earlier and the frontal cortex, unless they're experiencing stress. And in that case, that impairs the frontal cortex development, but the amygdala connections continue. Yes, thank you. And children who have experienced 3 or more ACEs before entering kindergarten have lower readiness scores. Literacy, language, and math skills are lower. And of course, rates of behavioral problems are higher. And I see that every day that I work. Next slide, please. So again, be that parent advocate, because this is at times what families think of trying to obtain services. So you have to help them navigate the system. And it's not just families that feel like this sometimes. Even I, who do plenty of referrals to infant toddler program and to women, infant, children program, sometimes I feel like it's a little complex as well. So continue to be that good parent advocate. Next slide. So ACEs Learning Collaborative, this is a collaborative that's happening in Idaho. And the goal is to increase the use of ACE and resilience screening in medical practices. And here you have the organizations that are leading this collaborative. Bill Foxcroft with you guys, the IHSA, Idaho Children's Trust Fund, Idaho Resilience Project, led by one of my favorite people in the world, Jean Mucci. And for St. Luke's, it's Dr. Tom Patterson. Next slide. And I like this quote. I've always liked this quote, but I think it seems even more relevant now in terms of relational health. If we have no peace, it is because we have forgotten that we belong to one another. And this is from Mother Teresa. So just slide just is illustrating that this topic is of utmost importance to the National American Academy of Pediatrics headquarters. Dr. Andrew Garner, who has been leading the charge in this for the last 20 years, is continuously coming up with good resources and good research to help us help our families. Next slide. And I don't know how many of y'all have seen this cliff analogy before, but we use it a lot in medicine. So you see the little people up on the top there. For medicine, what we say is we need to surround people with everything they need to maintain good health, what people like to call social determinants of health. And that red part, those little lines, is a gate. And so those are primary care physicians trying to keep people healthy and from falling off a cliff. And then in blue, you have secondary prevention. So those are the safety net programs. So for instance, diabetes centers and subspecialists like cardiologists and endocrinologists. And then at the bottom is the ambulance. So if you fall off the cliff and you don't have a safety net, yep, you're going to need an ambulance, which of course, as you get lower and lower on this cliff, you're getting more and more expensive, right? Well, I like to take this cliff analogy and use it for toxic stress prevention. So primary prevention is that red, which is that little gate. And though that looks like social emotional competence, that looks like preschool available to anybody who wants it, positive parenting techniques. And then your secondary prevention or your safety net programs are those blue arrows. And that includes Head Start, since by definition, you take those folks that they have to qualify through income. I put home visiting there, infant toddler program, WIC, and trauma-informed care, which is healthcare providers changing their questioning from why are you doing that behavior and why are you acting like that to what happened to you and how can we help you overcome that. And then of course at the bottom there are the most expensive services that we try to avoid but haven't been able to recently, and that's Child Protective Services, foster care, and the CARES Clinic in Boise that sees the children who are a victim of sexual abuse and child abuse. Next slide. So just a word on social emotional learning or social emotional competence. You'll remember that this is actually one of the 5 protective factors through the Strengthening Families framework. And the reason I want to talk about it a little bit is because it's kind of gotten a bad rap. There's a lot of misinformation about social emotional learning floating out there, not just in Idaho, but in other states as well. A lot of people think they're associating social emotional learning or SEL with bad things. They're associating it with indoctrination of children. They're associating it with critical race theory. But we have to, as the experts in early education, we all have to educate people who don't know about it and say that's actually not what social emotional learning is all about. I like to use the comparison to Robert Fulghum's concept, all I ever really needed to know, I learned in kindergarten. Now, this was popular back, I think, in the 90s, so I'm kind of dating myself here. But basically what Robert Fulghum meant by this is that most of everything you really needed to know to be successful in life, you learned in kindergarten. And those are things like listed below: share everything, play fair, don't hit people, put things back where you found them, clean up your own mess, say you're sorry, things like that. So that's, to me, what social emotional learning is. It means teaching children to become citizens of the world, teaching them how to relate to their family and to have empathy for others who have different ideas than they do, things like that. So I think that's part of our job as early education workers. Next slide. And we're finally to the homework piece. So these are things that I would love for all of you to do. I think Cam threw in the chat there our website through this grant that we have called Act Early Idaho. So if you could use that link in the chat to go to this website and then order at least one of the free materials that are available that promote development. Next slide. So these are some of the materials that are available. On the top there, that milestone moments with the purple band on the top, that's kind of like it's about passport size, and it's a little booklet that has all the different ages, and so you can track your child's development that way. In the upper right is the app through the CDC called Milestone Tracker. We'll talk about that in a little bit. We also have board books available. That's Baby's Busy Day. It's a board book for 1-year-olds. That one isn't always available, but if you want some, just go ahead and order it. And then when we get some in, we will get them to you and your program. That one's just a little harder to print because it's a board book and there's only a few places that are able to print that sort of thing. And then the rest here, it's hard to see, but they're basically just sheets that you can order that you can give out that, again, each sheet has a different age and all the developmental milestones that you would expect at that age. Next slide. So keep clicking. Well, actually, just click once. Let's see what happens. And maybe one more time. So I cannot give a presentation without at least having one slide about books. So one of the best things that you can do with your families is to encourage reading. I have started using the phrase brush book bed. There's actually a program called Brush Book Bed through the AAP where you hand the family a toothbrush and a book and tell them, you know, do this every night. But it works even if you don't hand them a toothbrush or a book. It just reminds them that this is what you're supposed to do every single night. And it helps with bedtime routine. You brush your teeth, you read a book, and then you go to bed. And you can start this as early as 6 months because, you know, that's usually when, right around when 6 to 12 months is when you get your first tooth. But you certainly can start reading at 6 months of age. And then one disturbing statistic that I got from Book It Forward, I don't know if y'all are familiar with the Book It Forward program, but that's one way you can get books in the hands of your families. But there's only one book available for every 300 children who live in poverty, whereas children in higher socioeconomic strata have 50 books per child. So there's only one book for those 300 children, and then that one child has 50 books. So that's the disparity there. And we know that reading encourages serve and return interaction and social emotional attachment because you're setting the child on your lap and you're cuddling them and then you're reading to them. So it's not so much about literacy as it is about that social emotional attachment and bonding. Next slide. And then here's the app that you can download. This is the Milestone Tracker app. It is free and it's available in English and Spanish. And on our website, you can order half-sheet promotional, like little promotional flyers that you can give to your families. You can also download the app if you're in a center, and you can use the app to track development for each one of the children in your center. All that you put in is a first name and a date of birth. And then it will follow along, not only with developmental milestones, but it also gives fun things that you can do with your child, and even what to do if there is a concern, if milestones aren't being met. There have been 1 million downloads just recently across the nation, and we are actually keeping track of how many app downloads that we have here in Idaho for our grant. Next slide. We also developed a Resiliency Toolkit. This is a PDF that you can find on our webpage. And it's also categorized by the 5 protective factors. And they're all of the resources on there are on the internet. And so we give a little description of what that resource is. And then if it looks like something that is interesting, then the parent can click right on it. And it's everything from YouTube videos to research articles to just tips on how to increase your own resilience, things like that. So please take a look at that. Next slide. We also developed a roadmap for childhood development. It's geared towards families, but of course, you know, you can take a peek at it too. If you use those QR codes, you can go to the 2 different roadmaps. We have a 0 to 3 and a 3 to 5 year one because that's how services are divided. And it's very quick and short, quite basic, but hopefully families will find this helpful when navigating, especially when there's a concern in their child's development. Next slide. So here are some fun Head Start statistics that I've pulled together. Because of the work you do, because remember, Head Start isn't necessarily just a program. Head Start is actually people. So because of what you do, the children who are involved in Head Start are more likely to pursue higher education. They're less likely to be obese. They're less likely to be involved in the criminal justice system. They're more likely to graduate from high school. They're less likely to become teen parents. They're less likely to live in poverty as adults, and 29% less likely to receive public assistance. Next slide. So never forget, you make the difference. You are very relevant in today's world. So pat yourselves on the back for picking early childhood as a career, because you are really going to be the ones that make the difference for our children and for our future. 100 years from now, it will not matter what my bank account was, the sort of house I lived in, or the kind of car I drove, but the world may be different because I was important in the life of a child. Next slide. Next slide. And that's it. One last thing I would ask you to do, and that is to attend the Strengthening Families Training Institute in March.